for joining on the third day on for the Oral Awareness Month, which where ICanCaRe along with the Foundation for Head and Neck Oncology, Sterling Cancer Hospital, and Gujarat University conducting this ICanCaRe second International Oral Cancer e-Conclave. So a very warm welcome to everyone to this third day of scientific session, and we all look forward to the panel discussions that we are going to have. So I now invite Dr. Kush Saad to kindly take and introduce for us for the panel discussion. Thank you so much.
Thank you, Rishabh. As we are running late, we'll start with the panel discussion for today. The topic for the panel today is local surgical procedures for oral cancer patients. And I'd like to welcome the moderator for the panel, Dr. Arun Pattatheyil sir. He is Senior Consultant Head and Neck Surgery at Tata Medical Center and Hospital, Kolkata. He is also the Secretary of FHNO. He has special interest in head and neck surgical oncology, tissue banking, and stem cell research. He has more than 40 publications to his credit, and he also has ongoing research for human oral cancer stem cells and cancer-associated fibroblasts from patients' tumors and the establishments of his primary culture, and to determine the genomic signature of oral cancer patients who has failed the treatment in gingivobuccal regions. I welcome Dr. Arun sir, and please take over the panel further. Thank you, sir.
I'll quickly go into to my duty of the day, which is to present a panel before you. And we are running a little short of time. I think exactly an hour behind schedule. So I would probably want very crisp, clear answers from the panel so that we can pass across some key messages. And of course, welcome Dr. K.Handa. You are there to moderate, and feel free to join in at any time. We'll be very happy to sort of hear your experiences. Okay, so we are joined by a great panel here. So a lot of learning is going to go on this 55 minutes that have been allotted to me. Very senior members like Dr. Shenoy and Dr. Mohanti, who I would say have been my teachers as well, and a lot of young Turks who do some great work all over the country. Srinivasan, and we have people spread across specialities. Like we have a radiologist, a maxillofacial surgeon. We have people from the plastic, hardcore head neck oncosurgeon like Dr. Dushyant and Dr. Shenoy. And of all the damage that we do, I think people like Srinivasan who come to our rescue time and again with his prosthetic skills. Thank you for having me here. ICanCaRe has been doing a great job over at least past few years in bringing various issues which hitherto are not discussed in routine fora like prevention and rehabilitation, and it's great to be here. So we are now moving in some from technology which is right at the forefront to something we have been doing for years, is doing local procedures for oral cancer in the mouth. But believe me, with the great panel that we have, we are going to get more perspective on things which we have been doing for times in the past. So just let me introduce the panel to you. We have exactly 55 minutes to go through that, and please do alert me when I overshoot time. We will stop at 55 minutes. So we have Dr. Srinivasan, who's a prosthodontist, Dr. Arjun Singh, who's a maxillofacial surgeon, Dr. Shetty, a radiologist, Dr. Mohanti, and Dr. Aparna, who are radiation oncologists.
Just a correction, Ratan is a head neck surgeon. So
okay, so from the list I got, I'm very sorry, Prathamesh. So we have one more the Oncosurgeon in the list today. And my slides have been prepared with the previous list of panelists, so it was a little path heavy. So forgive me, but I'm sure we have interacted so much with pathologists that our surgeons will be able to answer a couple of questions that I would pose across to you. So this case one, so we'll start with the first case. It's a 42-year-old housewife, and if you notice in the lower alveolus, there are a few teeth missing. So when this lesion started, it was believed that it was due to a dental trauma, and the first thing that a dental surgeon did was to take off her teeth. But she's so the tooth was sacrificed on that front, but the lesion continued to grow. I would also like to point out that it's if you look at it, they are multifocal. There are many small little excrescences that you see on the mucosa. It was painless, no comorbid conditions, and her initial biopsy revealed severe dysplasia, no invasive cancer. Please repeat malignancy if suspected. So that is a description. She did not have any nodes in her neck. So we don't have a pathologist, but I will go to the surgeons first, to whom these patients usually report to. So Dr. Dushyant, now that we have a biopsy in a multifocal lesion, it says there is no cancer. Are you ready to believe it, or do you want to go ahead and do something more? And if you're doing something more, what would you like to do?
Arun, I think I would like to know from where the biopsy was taken. It was in superficial biopsy from the keratotic area, or was it an actual biopsy from the junction of normal tissue and the tumor? Because it is really a very suspicious tumor, and there is a very high index of suspicion of invasive squamous cell carcinoma. So I will either redo my biopsy or like to redo an incisional biopsy or a punch biopsy in that case.
So, Dr. Dushyant, in a multifocal lesion like this, which one would you choose and how would you choose?
Most suspicious one I will do, I will take a biopsy of that, whichever is most clinically suspicious. I may take multiple biopsies also if it is required.
Dr. Ratan, anything more that you want to add? I will just put up a few things down and a few aids for biopsy. Do you use any? Ratan Shetty, we are not able to hear you. There's a lot of background noise. We'll give Dr. Ratan another opportunity. Dr. Ratan, we are not able to hear you. There is some disturbance in your audio.
Yeah, sorry.
Oh, there you go.
Okay.
Now,
so, yeah, I would tend to agree with Dr. Dushyant. I would do an incision biopsy from the most representative side. Regarding breast biopsy has been tried. You can take a breast biopsy and see cytology of the cells from the breast biopsy will tell us whether
this is a tongue lesion, Dr. Ratan. This is a tongue lesion, and there has been a biopsy.
I would always advise on incisional biopsy, because incisional biopsy is the gold standard for tongue lesions, which helps you in deciding what for the course of action needs to be taken.
Right. So I'll go over to someone senior. Dr. Shenoy, isn't it very sort of irritating sometimes that you have taken this biopsy, you have sent it to a pathologist, and here the patient stands with a negative report in his hand, and you are also frazzled. Now, what do you do? Why do this come negative in the first place? And what do you do about this? How do you deal with this situation? Dr. Shenoy? Dr. Ashok Shenoy? Okay, maybe Dr. Arjun Singh.
Yes, sir. So I think, sir, there can be many reasons for the biopsy to come negative, and in us, in this particular case that you put up, I think it looks pretty suspicious, but maybe the biopsy was taken from a less representative area. In other sites, I think because of the extensive keratosis, also because of the chewed tobacco, we might get a really keratinized layer, which sometimes does not, the basement membrane invasion is not particularly seen, and hence cannot be labeled as a invasive.
So mostly verrucous and proliferative lesions, right?
Yes, sir. So in those cases, I think incisional biopsy would definitely be more beneficial.
So shall I just put across to the panel that, there is no role for a scrape or a smear or a brush biopsy. You would all go for an incision biopsy in this case. And if possible, you would go for a deep biopsy, because in many of these verrucous lesions, in order to show invasion, you you really have to go deep down to the basement membrane. Shall we take that message across?
Yes, sir. I think
yeah. And if you have to repeat, Dr. Dushyant, how many times would you repeat? Because, going in for a surgery with a non-conclusive report is actually a pain for you and for the patient as well. Isn't it always better that we are both on the same plane? मैं cancer के लिए operate करने जा रहा हूँ. So repeat, and how many times?
No, exactly, Arun. If my pathologist says that I have adequate tissue, that it is not a tissue depleting biopsy, they are able to see the basement membrane in the tissue. I will not repeat the biopsy. I will explain my patient that this is a highly suspicious cancer-looking lesion. I would like to go in and operate you just like we do for the cancer, and we will wait for the final histopathology report and act accordingly. So I will counsel my patient in that front.
Any other way of handling these from the surgeon's team? Dr. Shenoy, are you there now? Let us all agree with Dushyant?
Yes, definitely, sir.
Let's all agree. So that's a great message that has gone through from this slide. Number one, no smears, no brushes. Going for a proper incisional biopsy from a clinically relevant area which you think is clinically suspicious. I don't think we rely on any visual aid for this biopsy. It's a clinical sense. So I think I put in pictures of fluorescence, and there is the blue dye, toluidine blue, which was, I think, it is not used anymore. I think we just go with a clinical sense. And if at all you have to repeat it, as Dushyant says, if you think your pathologist, the communication with the pathologist is important. If he or she has got an adequate tissue, and taking more is not going to help more. But if it's a superficial biopsy, it's worth going in one more time, because it's always good if your patient and you are both convinced that you are dealing with surgery. So with that, so let's proceed. So what we usually do in such situations is a different patient, just to show the punch biopsy. So the punch has got a very sharp cutting edge, and if at all it's a superficial biopsy, we would go deep and core out the tissue, so that will maintain the relationship between the different layers of the mucosa. If possible, we'll get some deep tissue to show in the invasion. And the problem with these punches is that, like this tumor, if the most important, the most suspicious looking area is on the alveolus, you can't use these punches. Another problem with these punches are when you go deep, you hit one of the vessels, and many a times you just put in a little cotton swab and ask the patient to wait in the OPD and the bleeding stops. Here you may have to either cauterize it or even put a suture. So in a busy center, that may call for some resources of time. And it is now recommended that if you sometimes, when the pathologist processes this tissue, they cut it at a tangent. In these tangential cuts, you may not capture the basement membrane invasion. So it's now advised that you put it over a piece of filter paper, and then you put the whole thing into formalin. So these are some of the changes. We do get a lot of these sort of cancers which look malignant, but it's never ever corroborated by pathology, and we try to get as much information from the little bit of tissue that we send down to pathology. So thank you so much. So now that we do a repeat biopsy. Right. So the biopsy comes as a well-differentiated squamous cell carcinoma. So we are now ready to treat the patient. How do we proceed with the investigation? I have given you a list of investigations. So we did a repeat biopsy here, and it did come positive for you. As far as imaging goes, again, surgeon's role here. What do you usually send for a patient with a lesion like that? Dr. Ratan?
Yeah, I would order the contrast and the MRI scan, because this is a sun lesion. So
it's an alveolus lesion. It's an alveolus abutting onto the alveolus.
Then I'll order the CT contrast and the CT scan to assess exit of the tumor and also to assess the image.
So, Dr. Dushyant, how do we usually, I agree with Dr. Ratan that he is going for a CT. So what is the decision-making process going on in your brain when a patient like this comes? CT or MRI? Dr. Dushyant, how do you decide?
Yeah, so usually CT scan is better for the lesions which are near to bone. And if you want to see enhanced soft tissue details like tongue or floor mouth lesions, then MRI is a better choice. In LVLS, we will like to see extent of the tumor as well as the bony involvement. So CT is a better choice at that. While in MRI, we want soft tissue delineation more. So MRI is better choice in soft tissue like tongue.
Right. So the role of imaging is to one, assess the extent of the disease, see its relationship with the bone, because that would impact the way you operate on these patients. And the patient is N0 clinically, but you would also want to assess the neck. And a CT scan with a contrast would be a good tool to assess the neck. But anyway, you would be going in for a neck dissection, in this case being a proven malignancy. But it will give you the status of the neck as well. So what about metastasis? In an N0 neck, the possibility of a lung mets it's really low. So would you do a CT chest or an X-ray in this patient? I'm missing Dr. Shenoy here. Like, is there a technical glitch? Because I saw him sometime earlier. Or is he not joining? Okay, we'll continue. So, Dr. Arjun?
Yeah, I think for a minimal, I will get a X-ray chest. It is an early lesion, and the likelihood of distant metastasis, especially to the lung, is very, very low. Right. But just to be safe, I will get a chest X-ray at least.
Right. We all agree. Any difference of opinion from my surgeon colleagues?
I agree with Arjun, as well as when you are going for a CT scan up to the base of the neck, up to the clavicle, they can just extend it down and take a CT thorax also at the same time. So if one investigation is serving both the things, no problem with that.
But you need to have a very compliant radiologist to do that. They usually don't do that. They said, that's a different investigation altogether. But I agree that, a chest without an N0 neck with a very early superficial tumor, you would not go for that. But rather, if it was a more advanced tumor, if there was bone erosion, if there were nodes, especially in the neck, I think I would go in for a CT thorax to exclude a metastasis before we go in to do any kind of an extensive surgery in these patients. Is it okay? Will you accept that argument? So we will proceed with that. So that's it, and this is the CTs that came with that. So we have two windows here. This is the one with the contrast. You could see the vessels are glowing up, and you see this is the buccal mucosa tumor abutting onto the mandible, but the cortex is intact. There is no bone erosion anywhere. How are we going to treat that? I think we'll have the surgeons coming in once again. So Dr. Ratan, what would be your management? So this is T2 clinically, abutting the mandible, no paramandibular spread, and no nodes in the neck. And no bone.
I would like to assess, I'd like to assess the extent of paramandibular spread.
I tell you why I haven't put the coronal scans. That a good question. That is another indication for taking down the bone, even if there is no erosion. But here I haven't put in the coronal scans, but there is enough bone height which you can get. There is no paramandibular.
This is a primary alveolar disease, and there is no bone erosion as such. So it is safe enough to do a marginal mandibulectomy with adequate margins all around and do an appropriate reconstruction.
Right. And now comes the bigger issue. So do we all agree that there is no frank bone erosion, there is no paramandibular spread, a limited disease, in spite of it being multifocal, we can still remain conservative? Hi, Dr. Shenoy, we are missing you. Shenoy, sir. We can't hear you. You need to jack up your volume. Okay, go ahead. We all agree, yeah, that it's
we can't.
Okay, we'll move on. So, Dr. Vipin, so how do you usually reconstruct your marginal mandibles. Your surgeon has done a marginal mandible. Most of the time they would do the reconstruction, I'm sure, with a small defect. But from a plastic surgeon's perspective, what would you usually do for a marginal mandible with a net dissection?
If there is a significant defect, sir, then radial artery forearm is one of the best options.
Right. So you would go to a free flap straight away, right?
No, if there is a significant defect, yes. And I can usually, I mean, whatever type of reconstruction you are going to have, you should have a backup plan. So I can keep a loco-regional flap option as a backup plan. I think this is a female patient.
42-year-old lady housewife.
Yeah. So submental, if the defect is small, then we can go think of a submental or a supraclavicular flap.
Dr. Dushyant, you are fond of local flaps. It requires a lot of ingenuity and creativity to get it in. Rather than free flaps, you can tailor it to the defect. So what are the kind of common soft tissue local flaps? Because this discussion is on local procedures for head neck.
Yes.
So,
yes.
Yeah, Dr. Arun, first and foremost, have we done an intraoral marginal mandibulectomy or not? That may enhance our armamentarium. If it's an intraoral marginal mandibulectomy, most probably we do not have an oro neck communication. So if you have a good floor mouth tissue with you, because this was an outer BA sulcus tumor, then you can just advance your floor mouth, cover your mucosa, and that will suffice. That is one thing. Second is that skin graft with bolster in that area is also good, because we are most probably dealing with a T1, T2, and 0 tumor. Most probably we will not require an adjuvant treatment, and a good uptake of the skin graft at that area will help us. Third is that we can use nasolabial flap here.
Yes, nasolabial is good.
Directly inside if that nasolabial skin is good, and we can do that reconstruction with nasolabial also. So there are multiple options which we have. Submental flap, I am not very comfortable, though they say that it level 1A and 1B are negative, you can safely use it. But in an BA sulcus, lower BA sulcus tumor, though it is an clinically N0 neck, I will be a bit hesitant to use submental flap. Yeah.
Okay, so great. So we have now, from our panel, we have got some very sort of, clear ideas of how a marginal could be reconstructed, right from just mucosal advancement to a skin graft to a local flap to a free flap. So again, the message that goes out here is that you need not remove the mandible every time. You can leave bone behind, which greatly improves function and cosmesis. If there is no paramandibular extension, if the patient has not been radiated before, you can leave an adequate stump of about 1 centimeter from the lower border. You will be able to get away with the marginal mandible. So one of the biggest mistakes I used to make at one point was to get this, cut like sharp, because this is an area where pressure would slowly sort of form when the patient starts chewing, and you may anticipate a fracture at this point. So now, please make it smooth and as rounded as possible. This is from a different patient. Here we did an intraoral excision. So how did marginal evolve? But at a time when oral surgery first started in the 50s, people believed that the lymphatics ran along the mandible. So it was Marchetta who first showed that you need not remove the entire mandible. You may very well preserve it. And Brown again showed that the pattern of spread may be very different. In an edentulous patient where the tumor is lying almost flush with the upper surface of the bone, it may enter through the attached gingiva. But in a dentate patient, it may even find its way from the point of contact, and there's another path through the periodontal ligament and into the bone. So a lot of studies have been done on that. And again, it does not affect prognosis. So this is from Australia, Chris O'Brien. is that marginal mandibulectomy does not affect outcome. Even, you are not able to truly assess the extent of disease, and you found that the bone margin is free, even if it is involved, but you can get a margin on the bone. Now, this is a very contentious issue. Dr. Shenoy, how do we know that the margin is free in a bone?
I don't believe that you can get that information intraoperatively because frozen section cannot be done on bone. However, however, having said that, what you can do is go to the periodontal, the reflection of the periodontal membrane or the mucosa over the cortex, and send that part. And that is very important. You ink that part and send it to the pathologist so that they will take the representative part to get some message across to the surgeon.
Right. Dr. Shetty, any idea? Do you do anything to find out your bone is free after doing a marginal, or you're happy with your soft tissue margins? Because many a times the disease fails not because of the bone margin being positive, because the soft tissue margin is positive. But do you make any efforts to find out whether your bone margin is free?
My decision regarding whether to do marginal or the segmental is preoperative, not intraoperative. So if I find that there is bone loss on imaging, it is safer to do a segmental mandibulectomy rather than a marginal mandibulectomy. Right. So my decision is done preoperative, not intraoperative, because there is no real way of knowing whether the margins are negative or not, because frozen next us frozen cannot be done on bone. We can send the margin sampling, but
Dr. Dushyant, anything like imprint cytology or anything you try to find out? Are you worried usually with the bone margin? It's okay. Once you have done your assessment on CT, you're good to go.
The thing is that when you are going for a marginal mandibulectomy, almost you are sure that you are going to get it. There are certain places where you are in doubt. Sometimes what happens that there is an removal of teeth and there is an enhancement in the marrow, but your tumor is actually not going there. But you are really worried that when you are cutting, it is your tumor or it is just an enhancement of inflammation. At that time, when we are in doubt, we send scooped out marrow from the patient side for frozen section. And our pathologist can tell us that this marrow is involved or not. So that gives us assurance.
Great point. Dr. Prathamesh, I think you were there, I remember having had a discussion with you on this, and Dr. Prathamesh had a very bright idea. He said, we can just sort of drill that area, get some bone dust and send it for a quick analysis. Prathamesh, any sort of, so that was a great tool. Have you made any progress on that yet?
Yeah, Arun, we have done a study and we looked at the bone dust. So we collected the bone dust from the bed of the tumor, from the edges and at the margins which we have predetermined. And what we found that we could actually identify atypical cells which would highlight the possibility of a disease process which you might then consider taking a wider margin. But I feel that in a patient who has no bone involvement, your margins are usually predetermined on the imaging and the extent of the soft tissue. And as you rightly said, and as most of the panelists agree, the failure is usually the soft tissue. So I feel more information needs to be ascertained. If you are in doubt whether the bone is involved, you might even consider using an MRI as a decision making or a troubleshooting tool, and then make a predetermined bone cut. But as we discussed, the bone dust is still being under clinical trials, and maybe once we are able to prove that it is a useful tool in the frozen section, we are going to come out with a publication mostly at the end of this year.
Thank you. I think I will just sum up this discussion here. The decision to go for marginal cannot be done on table. You have to go through your imaging to decide on the extent of your resection. Various techniques have been tried, like scooping out marrow and sending it for examination, getting bone dust. We used to send smear, just imprint cytology from the exposed bone, just put in a slide, press it onto that and send it over. But the biggest worry here was that, maybe there could be cells which have sort of separated out from the tumor during the process and contaminating the film, and that could be interpreted as positive by the pathologist. But again, I think as Prathamesh put it very clearly, most of the time marginals fail not because of the bone being positive, because you haven't got an adequate soft tissue. Dr. Shenoy, anything to add?
Yeah, I have a point. I would also ask you, when you're doing marginal mandibulectomy, to send the nerve margin from the mental nerve and also the posterior, where the anterior superior dental nerve enters the lingula. If that is also included in the posterior part of the margin, for instance, when you're including the coronoid process for a posteriorly based lesion, I think that should also be included, because it will give you some information in the final pathology, not immediate pathology, but it's a good idea to send the mental nerve and proximally and distally as it becomes a part of the mandibular nerve. So I
think worried about perineural invasion, sir?
Absolutely.
Got it. Thank you, sir. So again, margins free. It's quite big. It is like more than 2 centimeters. Margins free. So nodes were all negative. But there is a focal cortical bone erosion, and there is an increased depth. Here we need your help, Dr. Mohanti. Please come in. So does focal cortical bone erosion matter in the staging, and would you treat this patient for depth alone because it's P2, not yet 4 centimeters? The nodes are all negative, but 7 mm depth. Dr. Mohanti, can you hear us?
Yes, I am able to hear you. Good evening to all of you.
Thank you, sir. Thank you for joining. Great to have you with us.
Okay, my pleasure to be here with all of you. And I am learning quite a lot. So we are talking about two things. One is the focal cortical bone erosion. The other is depth of invasion. And we are talking about depth of invasion above 5 millimeter. So my request to the surgeons will be, will they refer the patient to a radiation oncologist or not?
Because so we would sit at an MDT usually.
And because you are the gatekeeper, because I saw a chat that from one of the panelists that let us keep the PORT reserved. So I want to know from the surgical colleagues, will you refer to the radiation oncologist to evaluate or not?
This is a googly, Dr. When I have somebody like Mohanti in my panel, I'll certainly use his expertise and take some inputs. I think I will do that.
Dr. Mohanti, he wants to make it in an MDT, and all the surgeons are looking at you now. So how would you do?
No, my request will be that
I would say, patient is scared. He wants radiation. What do we do?
Yeah. Okay. My requests are on 2 points. One is that we have realized that the radiation therapy utilization rate for head and neck oncology in the low and middle income countries are much lower than what is optimal. That is number one. That happens because the surgeons and the dentists are reluctant to refer the patient to radiation oncologist to evaluate. That's number one. For this case, in instance, I would say that because of the age of the patient and because of the depth of the invasion and having a marginal mandibulectomy, doing a very focal post-operative radiotherapy bed will not anyway compromise the outcome or the oral physiology of the patient. So my request will be that not to keep it in reserve, but to give the post-operative radiotherapy.
Dr. Aparna, do you share that view? This would actually be a T3 if it is AJCC 8 because it's an old slide. This is AJCC 7 is T2, but this would get upstaged because of the depth. So
because T2 with more than 5 millimeter makes it T3.
T3. It makes it T3. I'm sorry, it's an old slide, so that's why it's a T3. It's AJCC 8 would be a T3.
AJCC 8th edition, it makes it T3.
So would you radiate, Dr. Aparna, for one factor, just 7 mm?
Yeah, because it is the risk of local recurrence will be there, and I would also look for other factors like LVI, worse pattern of invasion.
So already negative, no adverse pathologic features.
But even the depth
is there. The depth is already incorporated into the AJCC 8, so it makes it T3. So have you all changed practice? We are all radiating small with little more than 5 millimeters depth. What is your practice, Dr. Dushyant?
Yeah, particularly because the tongue and the floor of mouth, these are the lesions where we give adjuvant radiotherapy even in T1N0 when the depth of invasion is more than 4 mm.
In buccal, ma'am? In
buccal mucosa, if it is well differentiated margins clear, T2N0 we can observe. But in tongue and floor of mouth, we definitely go for adjuvant radiotherapy.
Yeah, I have one question for Dr. Mohanti. If he is going to irradiate, would he irradiate only the primary, or since your neck dissection is free of any deposits, and I assume that your pathologist has done a thorough job, if that is the situation, will he irradiate only the primary and leave out the neck? I want Dr. Aparna and Dr. Mohanti to
so it's like this. No, I think Dr. Aparna wants to say. Please go ahead. Please go ahead.
Sorry, sir, you can go ahead. But just I want to say depth of invasion is the prognostic risk factor for the neck involvement, recurrence in the neck. So we go for the up to level 4, and we will go, the dose will be different. Like we will go up to 50 gray for the ipsilateral neck, level 1 to level 4, and then to the tumor bed, we go up to 54 to 60 gray.
No, but are you going to, since he has dissected the neck and you have not had any positive deposit there?
Yeah, because there are various studies which says that there may be some the chances of neck recurrence are more even if after the neck dissection.
Right. So I think I can understand that there is a lot of heterogeneity in the way we are thinking about it. For the first time, AJCC has brought in a pathological factor into the staging. We used to consider the multiple sort of adverse factors, and the practice in most centers was not to give radiotherapy for one isolated feature. Usually we take in a collection of either 2 or 3 adverse factors, but that varied from department to department. But AJCC brought in this depth, and when it is a sole factor, it actually upstages the disease to T3, forcing many people to give radiation for that. So of all the risk factors, depth suddenly took predominance. It has become a very major factor. So I do understand that's precisely the reason why I wanted to put this issue here. So I'm sure the house would be very divided on this. Many centers would give it radiotherapy being T3. Many centers would still consider it to be a minor factor in the absence of nodes, and all other pathological factors may well go without radiotherapy. So I just quickly, so how many would radiate? So Dr. Shenoy, what do you believe? Would you give radiation? Would you send the patient like Dr. Mohanti wanted you to send the patient to him? So would you send the patient for radiotherapy?
Yes, no. No, I don't think I will.
No.
I will take his opinion, but I will not.
Dr. Dushyant?
If I am really sure about my surgical resections, my margins are wide away, I will not send him.
Dr. Arjun Singh?
Yeah, I agree with Dr. Dushyant. I don't think
Dr. Ratan?
I also would not radiate.
Wow, lovely. So that's great. So even if AJCC calls it 8, we are still reluctant to treat this as T3, which would be locally advanced disease. So thank you for that message. Now, is cortical bone erosion ominous? Has it caused any change in the staging?
Dr. Arun, for alveolar tumor or for a buccal mucosa?
This is a buccal. This is a buccal tumor.
For a buccal tumor, a cortical erosion is bad. For alveolar tumor, the staging changes.
Right. Yeah, but this is in the lower alveolus.
So if it is a BS sulcus going to cortical bone and there is a cortical bone erosion, it becomes T4.
Okay. All right. So so when would you give adjuvant? Radiation oncologist on the panel. So of all these, how do you decide when to give radiation? So there are so many adverse factors other than depth. So would you choose one, two, many, any? What is your rule, Dr. Aparna? How would you choose? Quickly, we can just sort of tell us how we go.
I think we have some clear-cut indications, margins, close margins, positive margins. You would go for concurrent chemoradiotherapy as well, but only radiotherapy would be margins, nodes, and
would you send anyone? What do you think is eligible for that, or do you use a bouquet? You do use a combination of factors to decide?
I think if there is one, I think it definitely makes sense to go ahead because
yeah, and there are many emerging ones like WPOI is emerging, lymphocytic infiltrate is coming. So the lot on the horizon. There are many more minor factors which are going to make their way into our staging systems.
We are actually having a trial ongoing, sir, at Tata Memorial, and it's a multi-center trial, it's an ARREST trial.
Right.
Looking at the soft indicators for prescribing adjuvant therapy for late oral cancer.
Yeah, so thank you for highlighting that, because that issue is still unresolved, and very rightly said, we would need a good prospective trial from a country like us who treat a lot of oral cancers to decide on small early cancers when do they need adjuvant radiotherapy, or whether they benefit from whether they give it to a 1-factor, a 2-factor, or multiple factors. Let's now come to Dr. Srinivasan. Srini, we need your help here, man. So we heard our surgeons and we heard our reconstructive surgeons that there are various ways of reconstructing a marginal defect. The first picture will be a radial forearm, and the next one is the skin there. If it was left, the choice was left to you, and the surgeon said, I am open to whatever you tell me, Dr. Srinivasan. What would you tell the surgeon? What kind of reconstruction would you prefer as a prosthodontist?
Yes, thank you, sir, for getting us our specialty also on board. Now, here, sir, a lot of it depends upon the initial plan. So, I think being a part of the discussions initially with the entire team becomes paramount, because these decisions can be interrelated. Now, if you're, as you rightly mentioned here, if you're contemplating a bulky flap there, it definitely needs to be debulked before you go in for any kind of prosthetics. Now, if you have good enough number of teeth to be able to anchor a prosthesis, you need not always be contemplating implants for rehabilitation. You could seriously consider removable prosthesis as well if you have good number of teeth, and especially as we've already seen in the discussion that a lot of decisions are ifs and buts, and when you don't have a clear-cut clarity on the path ahead, I think it could be very well safe to consider a removable prosthesis to start with in the early days, and then take those decisions on a case-to-case basis as we move ahead. If you would want to take, if you want to involve implants, but if there is reasonable clarity on the path ahead, considering, for example, the age of the patient and otherwise, and prognosis and at least an initial gut feel on the need for adjuvant radiation therapy, it's not a bad idea to consider. I'm not saying to go ahead, but to consider even implants at an initial stage. It's not going to be easy because you are going to be placing the implants in the inferior border of the mandible, and you have the antagonistic dentistum, which is a bit more medial. So you may end up prefer to place the implants a bit more lingually tilted than otherwise. Either ways, I think the choice of prosthesis in my book would be a removable prosthesis and never a fixed one, right? Because maintenance becomes very difficult, and patients are generally sold out on fixed teeth, permanent solutions, they say. But I think we should all consider removable prosthesis very, very seriously in such situations.
So would a removable prosthesis sit on a boggy bed like a radial forearm, or maybe sort of a lateral sort of an infrahyoid flap? Do you think they need to be debulked before we can even give a removable prosthesis?
Absolutely, sir.
Pre-prosthetic surgery, right?
Absolutely, sir. Your bulky flap is never good for any kind of prosthesis, be it with implants or without it. So any soft tissue around implants is also not a good idea. So debulking the flap is always is going to be a good, probably a prerequisite, I would say, for any kind of prosthetic intervention.
But a marginal defect is very rehabilitable, if I can use that word, right? And every surgeon should try to get it done.
Definitely, sir. Definitely, I think it is definitely a good thing, even from a prosthetic standpoint, for an optimal rehabilitation with for patients.
So you already cleared this issue. Yeah, go ahead.
Arun, I wanted to ask the question: how do you plan the implant if this patient is to receive post-operative radiation therapy?
So Dushyant, sir, I think Dr. Dushyant very clearly said that if the patient had a node positive and he was going in for radiotherapy, he would not want an exposed bone there. Rather, a mucosal advancement or a skin graft would be lower down in his order of priority, and he would sort of put in a thicker, a bulkier flap, which would sort of vascularize that area better and prepare it for radiotherapy. So the picture.
No, what I'm saying is implant.
Yes, this is a bugbear of all oncologists. They think that if you radiate that little implant that you put in, they're likely to come out. So that is why Dr. Srinivasan, intra-op and delayed implants. How do you choose and why do you choose? And bring in the issue of radiotherapy, because many of these patients would be needing radiation. So would you put it before intra-op, or would you wait for the radiation therapy to be over?
So, from a technical standpoint, I would say I think there are enough studies these days to suggest that the outcomes eventually, whether you place the implants at the time of immediately after primary resection and reconstruction, or at a delayed stages, are more or less equivalent. But what the advantage you derive by placing the implants early on is that you get a radiation-free environment of about 4 to 6 weeks. Which you would never get ever later, and the vascularity is never really comes back to that stage ever once you give radiation therapy. So I would say it's a good idea to place the implants upfront. Yes, this is not a rule of thumb. I mean, if you've not been able to plan if you don't have pre-operative planning done for your fibula, for example, so are you considering marginal mandibulectomy?
Marginal. We have a discussion on marginal here.
Only marginal, right? Yes, only for marginal. So I think here it's going to be predominantly unplanned. So I think if you feel you can get into the OT, but if you feel that you don't have enough stock of bone, don't place implants. I would say at least 12 to 15 millimeters of bone is good. 10 to 15 I think is good. And either ways, if you're talking in the context of radiation therapy, I would still go ahead with place implants. If possible, simply because the moment the tissues are irradiated, should they be, you would have to wait for at least 12 to 18 months before you re-enter. And in irradiated tissues, the more you try to play around with the tissues, I think you're just asking for
One more important question I have. If the patient has oral submucous fibrosis which precludes adequate mouth opening during the marginal mandibulectomy, at the end of marginal mandibulectomy, will it change your decision?
Yes, it would. Because I would say then in that case, it's better to wait and watch and understand how how the patient's mouth opening is going to move, in what direction, and then go ahead. So if it's a case of oral submucous fibrosis, probably I wouldn't go in and place implants upfront.
Thank you.
I would probably prefer to wait and watch.
Dr. Vipin Barthwal, how quickly would you want a prosthodontist to go in and meddle with your free flap?
So soft tissue flap, if you are not doing it in same sitting, you're asking that.
Yeah, or would you want him to do it in the same sitting, and are you comfortable doing it at that time, Srinivasan? Enough bone height, all other things considered. They're putting in a free flap. Do you want to make a whole in it and put a implant at the same time?
Yeah. So, definitely. So that's my preference will be for a delayed implant reconstruction. Now, if radiation is not being done, so I think after 6 weeks it's a good time.
6 weeks.
Yeah.
So you don't want it to be sort of punctured at that point when you insert it.
Yes, sir.
Srini, what do you say? If I'm a bold plastic surgeon, say come ahead, go ahead, do it. I'm ready to take care of it. Would you do it at the same time?
Yes, if it's a free flap, and I think a lot of it depends on the kind of tuning you have and the way you've been able to work together. If you understand each other and you know where you're heading, I think placing implants at the time of primary reconstruction, in fact, saves the next surgery for the patient. But yes, a lot of it, I'm stressing on the word tuning and planning, because should you get the fibula wrong, then your implants are going to exit somewhere else.
Correct.
So I think just a question, sir. Pertaining to the patient which we are discussing, this patient has a marginal mandibulectomy.
Yeah. This is a delay. That's a radial flap which you see, very thick radial flap there.
But what happens in case of marginal mandibulectomy? Should we do it? I mean, as of now, I haven't seen being done at my institute the dental rehabilitation in the same stage. Yeah. Can it be, or should it be done?
We do it. We've done mostly in segmentals. We have got it to pass through. We have identified the perforators, and we make sure that we leave small fiducial markers there where the perforator is well preserved and protected, and then we do it at the same sitting.
In a free fibula. What about marginal?
Marginal, we haven't had a choice. This is the first marginal that we did. It was a radial forearm, and this was done delayed. The patient didn't receive radiotherapy, so we have debulked it. We have thinned it out. We have left the skin part of the flap on the bone, allowed it to, and then we have put in these implants there. I think we had a very great discussion. We didn't go into many cases, but look at the challenge of a small marginal. It has taken us an hour to go through. So it was a very wide-ranging issues that were covered with this single case, and I'm afraid we will have to stop with this one case because I'm not going into the second one due to paucity of time. I must thank all my panelists. You did a great job. You put across a few very key messages, and I'm sure ICanCaRe is all about about rehabilitation and putting the patient back on his feet, and nothing more than teamwork. Plastic surgeon, prosthodontist, oncosurgeons working together. It was really wonderful to get together on the same platform with all of you, and we continue this relationship in the operation theatre and the clinic as well. So thank you so much for joining.